thank everyone. Thank everyone for joining us. And because this month is Childhood Cancer Month, Childhood Cancer Awareness Month, we've invited two groups that serve children. We have Robin French from the Morgan Adams Foundation, who's going to tell us a little bit about what they do, and then Dr. Jenna Demitis from the Children's Oncology Hope Survivorship Program. So I think falling in line with exactly what we do here on the Survivorship Task Force. Before I have Robin share her screen and introduce herself and get started, I just wanted to let our task force members know that over the next couple of meetings, really probably starting in November, we're going to be working on identifying a goal or two for the task force for 2025. And so we need to start thinking about something that would be meaningful and line up with the Colorado Cancer requirements that we have through the CDPHE and such. So I think without further ado, I'll have Robin go ahead and share your screen and tell us about you and the Morgan Adams Foundation.
Okay. Hi, I'm Robin French, and I kind of have a foot in two worlds here. I do work for the Morgan Adams Foundation, and I have for about 12 years, and have been involved as a volunteer and other capacities for even longer. My older son is a brain tumor survivor. He was 2 at diagnosis in 2004, and he just turned 22 this year. So, so that's why I do what I do, and that's why the Morgan Adams Foundation exists. Also, Morgan Adams was a real little girl. Some people wonder if it was named for someone. It was. She was 5 years old and she was diagnosed with a GBM. And unfortunately, she passed away about a year later in 1998. And her parents started the foundation a few years after that, just as many parents do who want to honor their child and make something good happen out of something that's really crummy. Which is why my husband and I got involved in this world as well. Morgan actually drew this flower that you see. So it's a great reminder for all of us all the time.
Robin,
Can you see my screen?
We can't see your screen yet.
Okay.
There it goes.
There we go. So the Morgan Adams Foundation is more than 20 years old, which is a little bit unusual in this world. Many of these foundations started by families. Just the families can't maintain the fundraising and the effort and just with the emotional capacity. So we're proud to be a long-term supporter of this. As many of you know, cancer is the leading cause of disease-related death in children, and brain tumors are the leading cause of death from cancer in kids. They overtook leukemia a couple of years ago. 47 kids are diagnosed with cancer every day in the United States, and many more in other parts of the world. And sadly, most of those kids have worse outcomes than our kids do. Kids' cancers are very different from adult cancers, and they need specific treatments that are tailored to their growing bodies. Kids' cancers have a lower mutational burden, have fewer ways to kind of attack the cancer. And then you think about what the toxicities of chemotherapy and how that affects growing bodies, growing organs, not to mention the radiation, which I always joke with my son that first we poisoned him and then we burned him. And it's amazing that they survive as well as they do sometimes when I think about it. And now we have new cellular and immunotherapies that are great, but they do still have their own side effects and toxicities as well. So the Morgan Adams Foundation, we primarily fund research, and nearly all kids' cancer research is funded in the private sector. If you think about, there's over 300,000 people diagnosed with breast cancer in the United States every year, and there's about 17,000 kids. And So it's not a moneymaker for any drug company to develop and even produce many of the drugs that will help our kids. Um, so that's left to the private sector, academia, um, to perform the research, fund the research, and then particularly the early phases of it, and then they can go to the NIH for those coveted larger grants that really move the research forward, and then to fund the clinical trials. Um, Despite the progress that we've seen, there's still cancer types that there's one that's 100% fatal. There's some that are pretty low down there in the teens. But we have made progress. In the 70s. The average survival age for pediatric cancer survivors was about 48. In the 80s, we bumped that up to 53. Still not great. In the 90s, 57, while a normal life expectancy is high 70s. Um, Kids who survive their cancers are facing serious long-term side effects from that treatment. And I'm sure we'll hear more about that in a few minutes. But it's one of the goals of the Morgan Adams Foundation is to fund research that's not only helping these kids survive, but thrive, um, to find less toxic treatments. And I think we're seeing more of that, of kids being able to have less chemotherapy than they used to. And of course, that equals less time in the hospital, less immediate side effects, and fewer long-term effects. And the other side of it too is kids who survive their cancer are going to have on average about 70 years of, could have that much survival time with those late effects. Whereas with adults, it's more like 12 years. The Morgan Adams Foundation also, we started this during COVID. We had some social workers and patient navigators from Children's come to us and ask if we could help because they had families that were left with no income. In most cases, one of the parents either has to severely cut back hours or quit working altogether. And then during COVID, the other parent was left at home with kids who weren't able to go to a brick and mortar school. So they came to us kind of urgently and asked if there was anything we could do to try to keep some of these people from financial disaster. So even for folks who have insurance and even good insurance, the cost of cancer treatment is expensive. The copays, the deductibles, the treatments that aren't covered. Sometimes when kids are doing special treatments in other cities, that travel and all that is not covered. So there's lots of extra expenses that folks are dealing with, even on a good day. And then you just think about even in Colorado, if somebody lives in Durango, it's going to take them a whole day to get here for an appointment, a whole day to get back home. They're going to have to spend at least one night, potentially two. That's lost time from work, maybe having to get childcare for a sibling, think about gas costs, hotel rooms, food, all that. So we try to help take that burden off of the families, and there are lots of other organizations that do this work too, and we're glad to be able to collaborate with them. Which brings me to my next point, is that collaboration is essential in the pediatric cancer space. Researchers have to collaborate to make the best use of the limited resources. The obvious one is financial, is money, but it also includes sharing tissue, blood, CSF, all of that, and the related data that they get as a result of the research they're doing. We're finding more and more research funders are requiring researchers to share that information in either public databases or just in collaboration with other institutions. We're also seeing more folks requiring that they publish some of their work in open source publications so that people don't have to pay to access some of that information that could be helpful. Single institution clinical trials are rare because you're just not going to get a cohort of kids in one institution. I mean, which is the good news, that we don't have as many kids as with cancer as adults with, you know, kind of the biggies, the breast, the prostate, et cetera. So it just, by the nature of what we do, collaboration has to happen. We have a very active advocacy community in pediatric cancer, both at the state and local government levels, including the FDA, who the folks at FDA who are tasked with, you know, approving these pediatric cancer drugs are great. They're a lot of people complain about the FDA, but I've always found those folks to be super open to working with families, and they're just trying to keep kids safe through the process. The Cancer Moonshot folks have been very open to discussions and meetings. And then drug companies, more and more drug companies are asking parents to sit on, and patients, survivor patients, to be on advocacy panels to learn more about how they can help, how we can work together. And then the nonprofit organizations work together to serve the patients and their families in every way. I mean, it really runs the gamut what nonprofit organizations are providing. You see everything from gas cards and groceries, and, you know, the type of financial assistance we provide, you know, support groups, toys, trips, you know, it's all of it. And we all work together, one, to try not to duplicate efforts, because that's not helpful. And also to make sure that we're reaching all the families. We share information about each other with the families that we work with, because I mean, it doesn't do any good to have all of these organizations and nobody's using the services that we can provide. So we think it's critical to work together and always put patients and their families first as we're doing our work. It really can't be a selfish endeavor, because it defeats what we're all trying to do. So to that point, the Colorado Kids Cancer Association, the Morgan Adams Foundation, is a charter member. Joan Slaughter, the founder and executive director of the Morgan Adams Foundation, was one of the founding organizers of CKCA, the acronym. That's the URL that you can see there. And it's had some kind of fits and starts through the years of how active it's been. Right now, we're working to kind of reinvigorate it, update the website. We were on a pretty good roll, and then COVID, and then everybody was kind of trying to come out of COVID and get their nonprofit back rolling. And so now I think everybody's in a spot that we're interested in doing that again. We in the past have had monthly and then sometimes quarterly meetings where we have speakers sometimes to share information with us, that we share with each other what we're doing, the camps, you know, some of the people have sibling groups, all of that, just so we can have that information and be able to share. We've done resource fairs at Children's and at Rocky Mountain Hospital for Children, and just trying to, again, not duplicate efforts, and to save our time and financial resources to be able to put it where it is most useful. And a couple of times we worked on the state cancer plan. And so that's, you know, a role that this group has played as well. And then on a national level, the Morgan Adams Foundation is also a founding member of the Coalition Against Childhood Cancer, which has this acronym CAC2, and that's the URL for that. It does a lot of the same things, but on a national level, so much broader and larger. The Hope Portal is a database of organizations that have submitted information, and families, anyone can go onto the website and search that. If you go to the cac2.org, you'll find that. And then Better Together is the second part of this equation, and that's organizations that offer survivorship resources. So you'll see it on the website under the title Cancer Hub, and those two items are there. So the Hope Portal is more for families that are kind of during treatment, in the middle of it, and then Better Together for survivors. And then another tool in there is a survivorship toolkit. They spent years vetting resources that people submitted. There are over 500 resources on the toolkit right now, and they're already starting to update it. There's software that's trying to make sure all the links stay live and are correct. And it's really gotten great feedback from everyone who's used it. And we hope that anyone who can will refer folks there. It's not it's more of like a place to go get educated rather than, so Better Together is where you would go and find the organizations that might have support groups and that sort of thing. But the toolkit is really educational. And so I won't read it all there, but you can see all of the topics that are covered there. There's also on the website, there's a fact library that is vetted of all sorts of pediatric cancer facts. There's a scholarship listing that volunteers have put together. There's a lot there. So if you have anything to do with pediatric cancer families, it's a great resource to visit that website and see everything that is there. I had the privilege of serving as the board chair last year, which is how I know so much about it. And I've always been the Morgan Adams Foundation's representative to the organization, and really proud of what the Morgan Adams Foundation has been able to do with it. And this is my contact information. So if you want any more information on any of that, I'm happy to help. I mainly work from home now, and so that's my cell number. So that's going directly to me. And that's my email. Happy to put that in a chat if that's easier. But please do reach out if you have any questions or if there's any way I can help. And then I guess I don't have slides for kind of the second part of what I was going to talk a little bit about. And but I don't know if anybody has any questions that we want to open it up for any questions now before I talk about anything else. I don't see any hands.
Why don't you go ahead and then we can talk
okay. Yeah. So just a little bit on the survivorship piece. As I mentioned, my son is a 20-year survivor, and his healthcare, as most of these kids are, was very complex, and started off with a spontaneous hemorrhage. So we had that TBI to contend with as well. And so over the years, we're seeing more and more people, as we have more survivors, we have more physicians and nurses and organizations who are interested in survivorship. And that is exactly what we want. And the Morgan Adams Foundation wants, and what I want personally, is the need for more survivorship resources, because it means we have more long-term survivors. And so it is it's a long road. It's a road that never, I remember when Will, my son's name is Will, when he finished his last treatments, people are like, wow, it's so great, you're done. It's like, you're so far from done. And I saw somebody posted the other day on Momcologing and said, it isn't just a diagnosis, it's life-changing, life-threatening, and life-altering event for the entire family. And I think that's true. I think most families can tell you the day of diagnosis in their world is like before and after. And I think that's true with any sort of, traumatic event in people's lives. And but it is, I think that we've done a lot in this community to educate folks that there are these long-term effects, and part of what we need to do is find more appropriate, better treatments for these kids that aren't just little adults. So that's kind of what I had originally. And I thought that there could be some things that come up with Jenna's talk, and I'm happy to answer any questions or speak to anything specifically after that.
You know, one of the things I was just thinking, Robin, is that many of our task force members are serving adult survivors.
Mm-hmm.
And I wonder if they have, or if childhood cancer survivors are aware of the services of our adult survivor organizations that as they transition into adulthood might be able to take advantage of. And so I'm wondering about connecting some of our groups, we have a number that do a lot of outdoor, hiking and things for survivors, getting those resources connected to your toolkit through your Better Together.
Yeah, I think that would be fantastic. And I think, there's a lot of people who are kind of also stuck in that young adult, like teens, older teens and young adults who they don't want to go to camp with 12-year-olds, and sometimes the adult programs don't take them yet because they're in this kind of no man's land. So, I think it would be great to know about more resources. And yeah, I went to your meeting earlier this year and learned about a lot of the resources that are available to older survivors. So I think that would be fantastic to be able to share with our groups.
Great, and I think that's something we can certainly.
Because secondary cancers are also, obviously one of those side effects, and so some of them may end up with one of these other cancers that are more adult and could benefit from some of those resources.
So that would be great. Anyone else have questions or thoughts they want to share? I think that's really great to hear about. Okay, well, we'll transition over to Jenna to talk about what you do at Children.
Thank you. I was wondering if I get started, just to make sure I can continue, I can even further tailor my talk beyond what I already had, if I could hear kind of who everyone is and what their role is on this. Is that possible?
Sure, we can go through, like I said, we have a small group, but we are recording it. And so we will send it out to the rest of our task force. We normally have a few more than this, but if we want to go around and start, Erica, if you want to start, because you're the first person on my.
Sure, no problem. So I'm Dr. Erica Lovett, and I'm actually in Grand Junction, Colorado. I sometimes pop on these just because I like to be included and kind of know what's going on in the state. I do supportive oncology and survivorship, and so I see adults. We don't see any kids, but I do have several patients who had childhood cancers, and so working with them as well. And I also do medical acupuncture and trained in integrative medicine.
Ian, do you want to quickly say hello?
Sure. Hi, everyone. I'm Bing Walker. I'm with the Colorado Department of Public Health and Environment, and I am the Comprehensive Cancer Control Grant Manager. So typically, Karin comes on the call as she was a cancer specialist at CDPHE. Unfortunately, she has left us for something else. I also hop on the call to learn a lot of really great information, but how we also work with the task force and the coalition is one of the things that's coming up is the Colorado Cancer Plan. So currently the cancer plan is from 2021 to 2025. So we're in the process of revising the state cancer plan for 2026 to 2030. So all of the discussions that you guys are having right now is very important for our next revision of the cancer plan.
Thank you. Michelle, are you there?
I am here once I get unmuted. My name is Michelle Paterino. I'm actually a contractor working with Colorado HICPUF Medicaid department, and I am on our palliative care work group working to look at implications of potentially a benefit for Medicaid. So I am just here trying to continue to learn about what is happening in Colorado and what we need to know.
Lillian? You may have stepped away. Rebecca, are you there?
Hi, my name's Rebecca. I work as an occupational therapist. I was working with the adult population at oncology rehab, but I have been passionate about the cancer population and kids in particular. I currently work for a company called Kids Care Home Health. So I'm picking up that kids' direct experience in the healthcare piece. And I am just passionate about people living their best lives after going through or during the cancer experience. OT at your service.
Thank you. And then Ian, I think you are our last, if you're still on
Sure.
there.
Yep. Ian Kahn. I work with Bing at CDPHE with our cancer team. And I'm playing the role of tech support for today's call.
We'll give Lillian
Thank
one more
you.
chance if she stepped back. Lillian, are you there? I think she probably stepped away.
Hey, thank you so much. I have kind of, I'll share my slides and we can kind of talk about how much to go into each thing, because I want this to be as helpful as possible for you all, and kind of really meet your interests. So I was gonna, first of all, backing up, my name is, as previously mentioned, Jenna Demitis. I'm a solid tumor oncologist at Children's Hospital Colorado and the clinical director of our survivorship program as well. So my plan today was to do an overview of childhood cancer survivorship, including a tiny bit of epidemiology, what our patients are at risk for, highlight unique psychosocial needs, and the challenge of transitioning to adult care, and also talk about what our survivorship program here at Children's Hospital Colorado includes. So I think I will try to go maybe faster through some of the medical risks that our patients have, but just kind of highlight some really key things that they are thinking about and that we hope they're thinking about, we hope their providers are thinking about as they age. So over 400,000 Americans are childhood cancer survivors. The top diagnoses that patients are surviving are acute lymphoblastic leukemia, brain tumors as a group, and Hodgkin lymphoma. We know that our patients are from the treatment that they got at high risk of cumulative health burden. So by age 45, about 87% of childhood cancer survivors will have a chronic health condition. And 56% of these patients will have a grade 3 to 5 serious or disabling condition. So those are really significant conditions. And we also know patients who have a hematopoietic stem cell transplant for their cancer are at a 4 times increased risk compared to patients who do not have a stem cell transplant. We also know that our patients have suffer from accelerated aging. This is just a model picture of, so the blue line is your normal aging, and then the damage caused by the lightning by chemotherapy and radiation really just accelerates your aging. And then this is another more real data showing that survivors versus controls had at a cellular level and biomarker level accelerated aging, pace of aging, and epigenetic age were all worse. So that is something that really is something to consider for patients, that they may be more frail, they're at risk for diseases of older age at a younger age, essentially. And they also, unfortunately, even when they survive cancer and are 5-year survivors, have risk of late mortality. So you can see this is time since diagnosis going from 5 to 35 years out, and the top line is survivors compared to the expected based on US population data, and there's really a significant cumulative mortality for our patients. Our patients are most often dying from a recurrence or progression of their disease, but second malignancy is a huge risk as well. Other causes of death are kind of next, but then cardiac disease is really important, and pulmonary is a little bit increased for our patients, and I'll talk a little bit more about what that can look like. So second malignant neoplasms, or SMNs, are cancers that are caused as a result of treatment, essentially. And so it is the most common cause of non-relapse death in our patients. The most common type is breast cancer, followed by thyroid cancer. About 9% of childhood cancer survivors will develop an SMN at 30 years post by 30 years post-diagnosis. And SMNs, while breast cancer is the most common, as a bigger group, solid tumors make up 80% of these cancers. That can be sarcoma, carcinoma, brain tumors, and more. And the most important exposure here is radiation. Things that we have to think about when we're thinking about a patient's risk include their dose, at what age they were radiated, and how long it's been since radiation. Most of these do peak around 8 to 10 years after radiation, but that risk does continue on. I wanted to also highlight specifically breast cancer because it is the most common. So we know that risk factors for this are both radiation to the chest or axilla, as well as anthracycline exposure. And that's a newer finding that I think is less intuitive than radiation. So on the left, you can see just by radiation dose or dose to the breast, the odds ratio for developing breast cancer in these patients. And on the right, you can see both the anthracycline exposure also increasing breast cancer risk. We do recommend for our patients that they get proactive screening starting either at age 25 or 8 years post-radiation, whichever is later, so significantly earlier than in the general population. Just very briefly, some of the other screenings that we recommend. So for patients who had abdominal radiation, colon cancer screening at an earlier age, we don't typically recommend proactive lung cancer screening unless a patient is at high risk based on, say, also being a smoker or having a strong family history that's not smoking related. All patients should have annual skin exams looking at their radiated field. And thyroid cancer, as I mentioned before, is common as far as these go. However, screening is challenging because there is a lot of false positives. So this is more of a discussion with patients whether or not they would want to proceed with this. And then finally, brain tumors are also one of the more common SMNs, and this is patients who receive radiation to their skull or brain. We don't recommend proactive MRIs or CTs. It's really just symptom-based, but having a low threshold if a patient develops new headaches or new weakness or something like that, that they really deserve imaging. The second really big category we talked about previously, and that causes of mortality, is cardiovascular disease. In compared to our general population, our childhood cancer survivors are at 15-fold increased risk of developing heart failure. And we know that this is the third leading cause of death for survivors and the leading non-oncologic cause. So this is really important. And it's really important as they age. So many of these patients don't really develop these issues until long after, when they are in the care of their adult medical providers who may or may not know their cancer history in detail. We know that patients who are younger when they're treated are female, have higher anthracycline dose or trust radiation, are at increased risk for cardiovascular disease. So we cancel in a risk-based fashion. But we talk about for patients who have anthracyclines or radiation, cardiomyopathy risk, coronary artery disease risk for patients who are radiated to the chest. And then along with when we're talking about these things, it's critical to focus on risk factors that are normal cardiovascular risk factors, such as dyslipidemia, hypertension, obesity. We know patients who are survivors have this additive risk when they have those typical cardiovascular risk factors and their exposure from their treatment. Patients can also develop pericarditis, valvular disease, or conduction abnormalities as a result of radiation. This is just graphs showing these things. So the blue lines are patients who are radiated and yellow is no radiation. And then at the bottom, you see both radiation and anthracycline. And you can see that there's a significant cumulative risk where the blue line is radiation and anthracycline for risk of heart failure. Yellow is anthracyclines alone, followed by radiation. And then patients who have neither are really pretty much down by their siblings in terms of their cumulative risk. We also know that our patients are at increased risk for those cardiovascular risk factors on their own. So childhood cancer survivors are more likely to have hypertension, dyslipidemia, multiple risk factors, and diabetes. We know that our patients have some increased risk of obesity, but this isn't always very prevalent and is often misdiagnosed because patients may have sarcopenic obesity where they are not, their BMI may be in a normal range, but they really don't have the kind of healthy body fat mass, basically. Just again, super briefly, depending on their exposures, we recommend lifelong echocardiograms. We also recommend for patients who have radiation to their chest, a formal cardiologic evaluation 5 to 10 years after, and then to just be hooked into care because of their increased coronary artery disease risk. And that is more difficult to screen for. It's not going to be detected on an echo. So really having somebody who can have some expertise thinking about whether or not they need proactive stress tests, et cetera. And then for patients who are pregnant or planning to become pregnant and have a high risk, proactive echocardiograms before or early in their pregnancy are also something that we recommend. Very briefly, lung disease. Our patients are at risk for pulmonary fibrosis from a variety of alkylator chemotherapies, bleomycin, and radiation. And then just more generally, restrictive and obstructive lung disease are elevated in these patients compared to siblings. And this can occur pretty late as well. So it's something that if a patient is symptomatic, that warrants workup. We in survivorship care and childhood survivorship care do pulmonary function testing when they enter survivorship, but again, this might not be when they have the symptoms. And so thinking about that as they age as well. There are many more late effects that I could talk about, and for the sake of time, do not plan to, but I also wanted to highlight briefly infertility and hypogonadism. This is such an important quality of life issue to patients, as I'm sure you all know. So first of all, patients are at risk for gonadal hormonal dysfunction. This could look like delayed or absent puberty if they are young when they're treated. If they're post-pubertal when treated, this could look like premature failure, hypotestosteronism, or ovarian failure. And patients are at risk for this from a variety of things, whether it be central, where they have a central CNS exposure like radiation or neurosurgery, or a gonadal surgery, various chemotherapies or radiation to their, that includes their ovaries or testes in the field, or total body radiation. We, in survivorship care for our young patients, follow them developmentally, but as they get older, even if they reach a developmental maturity or were post-pubertal at the time of treatment, they really still need to be monitored for that longer term. Similarly, our patients are at increased risk for impaired spermatogenesis or a decreased ovarian follicular pool. And the exposures are similar to what I mentioned before, but being proactive and thinking about semen analysis or monitoring for follicular pool using anti-Müllerian hormone are ways that we can kind of be proactive and try to catch patients if they are having a drop off in their fertility before that is truly gone, so that they can consider if they'd like to go under intervention. These interventions, pre-treatment, we use cryopreservation in prepubertal females. We can preserve ovarian tissue. And in postpubertal females, we can do oocytes or embryos. And in males, it's experimental to do testicular tissue, but we are doing that. And then postpubertally, semen extraction or more traditional semen banking, sperm banking is another option. Post-treatment, again, monitoring reserve or semen quality so that we can then intervene and do similar cryopreservation as desired by the patient. This is fortunately getting some more and more insurance coverage, and then we, of course, work with organizations to help support patients who have financial limitations as well. Our patients also, just moving on to quickly, neurologic issues. I know that this is obviously something huge for say, our occupational therapists, but patients are at risk for long-term peripheral neuropathy, cerebrovasculopathy and moya-moya disease and stroke, and then seizures and focal deficit. So these are things we're always screening for as well, and thinking about ways we can optimize quality of life. And then our patients are, just like adult patients who undergo treatment, at risk for a neurocognitive impairment, but pediatric patients have a little bit of different risk. First, their brains are more plastic when they're younger, so that is good for them, but they also are getting treatment when they are at a critical point in development. So they are at risk for functional deficits in executive function, attention, memory, processing speed, visual motor integration, and fine motor dexterity. They also may have learning deficits, particularly in math and reading comprehension. Radiation, cranioradiation, and neurosurgery are major factors for this, but also some chemotherapy such as methotrexate and cytarabine also increase this risk. And importantly, this may not occur until late after treatment. And so these new deficits may emerge over time. Patients require ongoing screening and talking about how are they getting through their day, being proactive about considering a neuropsych evaluation and thinking about whether or not they warrant work or school accommodations. So as patients get older, we recommend regular evaluation and updating IEPs for young patients, but as they go to college, that's another time that we think about whether or not they need neuropsychiatric evaluation, so that if they do need some accommodations at their university level or at their work, that we can help advocate for that. Psychosocially, any cancer experience, as you know, is traumatic. Pediatric or childhood cancer survivors are at increased risk for social withdrawal, educational problems, relationship problems, underemployment, and dependent living. They have increased mental health diagnoses, risky behaviors, and poor health-related quality of life, namely fatigue and sleep issues that we are always trying to detect and hook them in with the care that they need if they're developing these concerns. Highlighting now unique needs of adolescent and young adult childhood cancer survivors. This time period is such a critical time for patients. They're developing their own identity. They're wrestling with body image, which can be drastically impacted by the fact that they had or have cancer. They're trying to figure out how to develop intimate and emotional relationships. They're figuring out how they are independent from their parents and how they can start to have their own independent decision-making about future goals and about their health. So as we're thinking about this, we're also thinking about the ways that cancer disrupts AYA's life. From self-esteem and body image, as I mentioned, to trust in healthcare, disrupting their education or their career plans. They can have long-term financial implications, even if they were young when they were treated, but AYAs are at increased risk for this. family dynamics are disrupted, their future plans, whether or not they're going to go to college as they planned to, or move away from their parents as they thought they would versus feeling like they need to stay closer. Fertility, as we mentioned, is another important thing. And then peer relationships and health behaviors can be drastically affected by these diagnoses. So adolescents and young adults really need specific healthcare and screening to think about all of these aspects of care. So this can include age-specific supportive care, fertility counseling and evaluation, psychological support, education and career development support, discussion and addressing sexual health, addressing behaviors such as as they start using alcohol and substance abuses and what they need to think about in terms of their health for that. And really having this kind of whole person care in light of each unique individual's developmental age and stage. So along with this, transition to adult care is a challenging thing, including for survivors who are even long-term survivors and had cancer as a younger child. So first of all, we unfortunately know that about 1/3 of adult childhood cancer survivors report receiving cancer survivorship focused care, meaning that 2/3 don't. We know that about 18% report that their survivorship focused care included either advice about risk reduction, so talking about things like cardiovascular disease or risk of secondary cancer, or discussion of ordering tests. So this is what we would consider to be an adequate long-term survivorship care. And this is really challenging. Challenges include access to specialized care. There are few dedicated adult survivorship programs, as you guys know, that see patients long-term as opposed to a touch point. Further, this is particularly important because in an adult who is 40 or 50 years old, when they hear that touch point, they may be able to conceptualize, okay, I need to do these things. I need to be proactive with my PCP to get this care that I am being told that I need long-term. But a patient who is 18 and getting this education is not going to take that down the line with as much consistency. We also know that a lot of patients don't have a PCP that's caring for adults. So they're making this transition from their pediatrician to family practice or internal medicine. And sometimes there's a gap in that. We also know that primary care providers often don't have a keen awareness of the needs of childhood cancer survivors. There can be insurance or financial concerns, patients' readiness in terms of their transition. They're comfortable with their oncology providers in their children's hospital, and it can be scary to go to a new provider who doesn't know their history. They also probably have had more involved parents in their healthcare than that average young adult. And so thinking about how they establish health independence and the ability to advocate for themselves and to navigate the healthcare system are all challenges that patients are particularly reaching. And we know that our patients, despite our best efforts, have limited knowledge about their health conditions. When you ask them, what was your diagnosis? We get answers like blood cancer, leukemia, but not the specific type, things like that, bone cancer. And so really not having the specific details of what their diagnosis or their treatment was. So that's where our survivorship program comes in, and we try to do our best here. So our regular survivorship care is called Hope Oncology Clinic. For patients who are at least 2 years off therapy and 5 years from diagnosis, they come to us instead of their primary oncologist. And they come to us until they're in their young adulthood when we transition them, which I'll talk about next. When patients first come to us, they have a multidisciplinary visit. They see an oncologist who is a survivorship specialist. They get education on parents and patients get education on the treatment that they received and what that means long-term. They get an assessment by a psychologist, a dietitian, and cancer genetics. This aims to try to address some of those broader psychosocial needs and health behavioral needs that we're trying to establish healthy lifestyle. Then our patients are seen annually by the oncologist and the nurse that does repeat education. And then we loop in these other services and other specialists as needed for patients who have identified needs. So the purpose of this is not only to do our proactive screening like echocardiograms, but really to re-educate, reestablish the need on healthy lifestyle, and to reassess psychosocial or neuropsychologic needs. Then we recently developed our transition to adult care program. So this program is, I think, maybe 4 years old, 3 years old. Starting at age 16, our patients undergo a transition readiness assessment and transition-related counseling, starting to encourage them to think about healthcare independence, think about how to make their own appointments, etc. Then sometime around 18 to 20, typically, depending on when they are ready, deemed by the readiness transition, the readiness assessments, and according to other things like when they were treated, how far off treatment are they. We do a multidisciplinary day where a patient gets their standard survivorship visit with their medical provider and their nurse. They attend a group session with a psychologist who talks to patients about mental health in adulthood, fostering independence, work and school accommodations, reviewing how to talk to their doctor about their cancer diagnosis and explain their medical needs, how to make a doctor's appointment, etc. There's a lot of role play that is done. And then they also meet with a health navigator who educates on health insurance and reviews the patient's own personal situation to kind of talk about whether or not they need any assistance in applying for public health insurance versus if they're going to be remaining on their parents or their schools. We also have a genetic counseling group session. This is less to talk about an individual patient's risks for having a predisposition and more to answer questions that a lot of patients have about what does it mean for my future kids? What is my risk for future cancer? And kind of more broadly, and then individual sessions may occur afterward if needed. And then once the patient is ready, has an adult provider that takes care of adults, we then do a provider to provider verbal handoff to try to really get them established with a primary care provider who knows their needs. In addition to this, we have a longer standing clinic called Tactic Clinic, and that is a partnership with UC Health Internal Medicine. The goal of this clinic is to take care of adult survivors of childhood cancer and improve access and adherence for our patients. Patients above the age of 21 can come self-refer or be referred by their provider, or sometimes we refer from Hope Clinic if that is just felt to be the best approach for an individual patient. They have a single consultative multidisciplinary visit where they meet with a pediatric oncologist and nurse, internal medicine nurse, an internal medicine physician that's just missing here, sorry, and a psychologist, and they get a full assessment and education again. After that, patients who are local and who need a PCP can be established with that internal medicine doctor, if assuming she has space in her practice, which usually she saves for these patients. Or if they already have a PCP or don't live locally, we encourage them. More recently, we started encouraging them to check in with us. Every 5 years, let's make sure you have updated guidelines and an understanding of what you need. So, sorry, shared office. But so those are the offerings that we have. I'm happy to take questions or yeah, love to hear recommendations or thoughts.
Just for me, I think this is super exciting, and we're in the middle of this right now. My son is 22, and he recently had his multidisciplinary clinic visits, and we did go through all this and starting that transition, and you know, it's a relief to know that that some of these resources are in place now, and that not just my family, but you know, all the families have this available to them. So thank you very much.
Yeah, that's a fantastic program. Thank you. How are you all at the Hope Clinic sharing survivorship resources? Not just kind of the scholarship and things, but or are you sharing like connecting them to the Morgan Adams Foundation or to the CAC?
Good question. So when they enter survivorship, they get sort of a packet of some resources. And then in our transition program, we have some written documents that we give, which do include specifically tailored to AYAs, some resources that patients have beyond scholarships, absolutely. So other programs, but I think we're always looking to beef that up, and I'm excited to check out some of the websites that Robin mentioned. The HOPE program, just saw this question, is a medical clinic. So it is billed as expected. And so for the multidisciplinary visits, those patients do have billing from each of those providers, but we work with families if there are challenges and we can kind of address that. And the Children's Hospital is also pretty good about that as well.
Well, thank you both so much. I am really going to encourage our task force members that miss this to listen, because I think this is really great information for them. And I am kind of hoping we can partner a little bit. We have to come up with a goal for next year. And I'm thinking something along the lines of trying to get our members who have services that might be appropriate for young adults and adult or survivors that are dealing with later cancers connected, so that everybody stays connected. But thank you very much for your time. I appreciate it, and I
opportunity.
Have a great afternoon.
Thanks
everybody.